Many thanks for all the urology trainees who have joined in our YouTube channel to discuss the urology exam preparation revision series. Today we are going to discuss various rare scenarios which could be asked in any urology exit exam. Many thanks for the trainee who has given the consent to record this session so that it will be a good resource for revision on a later date. Okay, you have a 71-year-old gentleman. He presented to A&E with history of weakness and temperature. He was treated for sepsis. His sepsis was found to be due to pyonephrosis on the right kidney. He was treated well. He had nephrostomy, and then later nephrostomy was removed since he improved completely. Follow-up investigation showed that his right kidney is now quite atrophic and his left kidney was never seen. He's like by birth solitary right kidney, which is also now atrophic due to the septic episode. What do you think his future renal functions will be? What is your advice for him?
So for this patient, I want to check his baseline kidney function at the current time by checking his serum creatinine and eGFR. And also I want to arrange for renal isotope scan, which is a DMSA scan, to assess the residual function on the right kidney.
Okay.
And this will give us an idea about his how his kidney function will evolve in the future. Also, some other clinical parameters like blood pressure, the presence of proteinuria, all this will help to predict the progression of his renal disease.
Okay. His baseline eGFR before this septic episode was 58. Otherwise, he's doing well. He's on single drug, well-controlled hypertension. After this episode, he had DMSA, as you said, which showed absence of the left kidney, as we know, and the right kidney is also having function like 8%. And so, in essence, he is heading towards end-stage renal failure. You said it's nice to have this baseline renal function before taking anything forward. What do you mean by baseline renal function? Which parameters you will look for?
So I'm looking for the serum creatinine, and through which we're calculating the glomerular filtration rate indirectly. And this, according to this, we can classify the patient with chronic kidney disease into different stages.
Okay, what do you mean by the glomerular filtration rate?
So is the rate of filtration of a certain substance through the kidney over a specific time. Ideally, we should use an inert substance for that, which is neither secreted nor absorbed by the tubule, and should be completely filtered by the glomerular filtration rate. The best substance to do that, however, is inulin, but it is very difficult, technically difficult and expensive to use the inulin. Therefore, we are using creatinine in our day-to-day measurement, although creatinine is not the typical substance because it is excreted in the tubule. About 10% of the creatinine is excreted in the tubule, so it's suboptimal, but we use it and to estimate the glomerular filtration rate indirectly.
Okay, so if we use creatinine, will it falsely give the eGFR on the higher value or lower value?
There are some caveats in the use of creatinine because the level of creatinine excretion in every person is different according to the age, to the sex, to the race, and to the muscle mass. So most of the equation which calculate the GFR through creatinine, they add some correction factor, especially if the patient is female or he is from Afro-Caribbean origin. So when the patient has a muscular body mass like bodybuilder, the eGFR, the creatinine tend to overestimate the eGFR, while a lady, thin lady, very few muscle mass, the creatinine tend to underestimate the eGFR.
Okay. What is the formula you are trying to explain?
We have many formulas to calculate the GFR, include the Crockett-Gault formula, which based on calculation from normal population. And then we had the MDRD formula, which is based on calculation from patient with chronic renal disease, and it includes correction for female and Afro-Caribbean race. And the most accurate is the CKD epidemiology formula, which is used by most of the hospital currently, which contain a correction factor as well for female and Afro-Caribbean race.
Okay, so this patient, what is your advice? Now his renal function is heading towards the wrong direction. What is your advice?
So I will involve my colleagues in the nephrology in the management of this patient. And usually the management at this level, since eGFR is 58, will be expectant by controlling blood pressure and try to avoid any nephrotoxic medication, regular estimation of his protein and albumin creatinine ratio in the urine, regular checking of his kidney function. From my side, since he had a previous history of infection and sepsis, I'll try to find a reason or an obvious source for the infection, if there is anyone, to be treated and eradicated. If the infections are quite frequent, then I may need to keep him on low dose prophylactic antibiotic in order to preserve the remaining kidney.
Okay, so this patient is heading towards the nephrology care. What do you think the nephrologist will do?
Usually the nephrology will continue observation most of the time until the patient reach into the stage of into the end stage renal disease. When he reach into this stage, then he may need to have dialysis or possibly renal transplantation at some point.
Is there any stages in end stage renal disease?
I know the stages of the chronic kidney disease.
Yes.
We have 5 stages. So CKD 1, when the eGFR is more than 90 ml per minute, but the patient is having moderate or significant proteinuria in the form of albumin creatinine ratio more than 30 milligram per millimole. CKD 2, when the eGFR between 60 to 90. CKD 3A, 45 to 60, the eGFR. CKD 3B, which is 30 to 45. CKD 4, which is 15 to 30, and CKD 5, which is less than 15 ml per minute.
Okay. You said hemodialysis. Define hemodialysis and how it differs from hemofiltration.
So the hemodialysis, this process is based on the concentration gradient is a driving force. So the idea is that there will be it will be a permeable semi-permeable membrane between two fluids with a counter current flow. And then there will be movement of the solute from the high concentration to the low concentration. And usually the blood is the high concentration and the dialysate is the low concentration. And at the end of at the exit of the filter, there will be equilibrium between the two sides. So in hemodialysis, the driving force for filtration is the concentration gradient, while in the hemofiltration, it's a process of filtration of the blood and also fluid replacement at the same time. And the driving force for filtration is the pressure gradient between the two media, which are the patient blood and the filtrate. So most of the solute will go from the patient blood into the filtrate, and then any fluid or volume loss will be replaced before the blood go back to the patient. The advantage of hemofiltration is that it is a slow process, but associated with less incidence of hypovolemia and hemodynamic instability. Therefore, it is preferred in a critical patient like an ITU or hemodynamically unstable patient.
Okay. What is the role for urologists, say for example, creating vascular access for hemodialysis?
Yeah, for the hemodialysis, we need to create an AV fistula, which is usually done in the radius. I think it is radiocephalic, radiobrachial fistula, done in the radius. And after we do the fistula, we need to give the patient some, we need to wash it with heparin to prevent clotting. And then we need to wait for about 6 to 8 weeks for the fistula to be mature, and then it can be used for hemodialysis.
So, what is the mechanism in which this fistula is useful for us?
The mechanism is that by creating an AV fistula, we will induce arterialization of the vein. So the vein will become large and obvious, and so easily can be calculated, easily can be cannulated. And this will make the process of hemodialysis, because the patient will need to do that quite frequently, 3 times a week. Therefore, he needs a good access, and this hand, which contains the fistula, should be labeled clearly in the patient, not to take any blood sample from this hand, not to apply any tourniquet or anything on that side.
Yeah, so this arterialization of the veins results in building up of multiple muscular layer in the veins wall, so that the vein will withstand multiple punctures, because the vein is the only way you can get the blood, and also you can transfuse the blood which has got filtered back into the patient. You can't puncture the artery, because once we puncture the artery, you can take a sample, but you can't infuse, because from the artery it will go into the capillaries, which is not the correct way. So by arterialization happens because the artery is directly connected to the vein, because of the high pressure in the artery, which is forcing the vein also to get hypertrophy of the venular walls. Okay, good. Is there any other dialysis where urologist has a role? Any types of dialysis you are aware of?
The other type of dialysis is the peritoneal dialysis, in which we are using the peritoneal membrane as the semi-permeable membrane between the patient circulation and the dialysated fluid. So usually we need to insert a tube, a think of catheter, into the peritoneal cavity, and then the dialysated fluid will be poured into the peritoneal cavity, left there for a while, and it should be heparinized, and then after that the fluid will be drained.
So what is the mechanism, how it works?
I think it works by a similar mechanism to hemodialysis, which is concentration gradient between the patient circulation and the dialysated fluid, and the peritoneal membrane will be the semi-permeable membrane in between them.
So what is the procedure by which this catheter is placed in the peritoneal cavity?
So think of catheter can be placed under can be placed under general anesthesia, either by open or laparoscopic method. Usually it's inserted below the umbilicus, and it is kept subcutaneously to the side, so it will be exiting from the side of the patient.
Okay. What are the disadvantages of peritoneal dialysis?
The disadvantage is that it's associated with infection, risk of injury during the initial insertion of the catheter. On the long term, with the repeated infection, there will be some fibrosis of the peritoneal membrane, and then it will become less effective. So it can't be used for a long-term management of the patient with CKD.
Okay, well done. So these are the main questions which can be asked in relation to the CKD or end-stage renal disease related urology questions. And I think you have covered the theory aspect very nicely, and also the practical urology aspects. Happy to go to the next scenario?
Yes, please.
Okay. You are attending a theatre list on behalf of your colleague. Unfortunately, the colleague needs to isolate because of the COVID infection in one of his family members. The theatre list has following patients. Have you got a pen and paper?
I just. Yes,
Okay.
please.
There is a patient waiting for venous gangrene debridement. He is diabetic. Second one, there is a patient who needs ureteroscopy laser lithotripsy for 8 millimeter left VUJ calculus. Third, there is a patient who is known to have stent on the right side because of a large renal stone, but she is pregnant. She is in third trimester. She's coming for a stent change because of the repeated pyuria and infection episodes, elective stent change. She has 6 weeks for her date of delivery. The fourth patient is a child waiting for circumcision under general anesthesia. So how are you going to arrange these 4 patients?
So my order in the list, usually the priority, and none of these patients has any allergies or anything.
No. No.
Yes, thank you. So my priority, usually we need to keep the child first, and at the same time also if we have a diabetic patient, we prefer to keep the diabetic patient first so we can avoid the use of a sliding scale for the control of his blood sugar. However, the diabetic patient is having a fournier gangrene as well, which is an infective case, and usually we prefer to keep the infective case at the end of the theater. We can do it in the beginning, but there will be a delay because we need to allow a good time for cleaning and cleaning everything after the case. So I would say if the patient is hemodynamically stable, the fournier gangrene patient, and his biochemical markers, everything is fine, started an antibiotic, the fournier gangrene maybe not that extensive, he can wait for 2 to 3 hours and we can do him at the end of the list. Otherwise, I may need to speak with my colleague, the on-call team. They may be able to do his case in the emergency theater list. So the order will be the child first, I will do him. And then after that, I will do the pregnant lady with the stent exchange. And then I will do the ureteroscopy and laser. And then finally, I will do the fournier gangrene if my colleague couldn't get the chance to do him in the emergency theater.
Okay, that's the very nice way to, I will say, build the cat, because there is no one specific strong answer. One way you can also substantiate your answer better is there is at least more than one patient in the list which requires to be done first in the list. Say for example, we prefer to do the child first in the list. We prefer to do the pregnant lady first in the list because the theory team is fresh. We don't want the pregnant lady to wait and push to the end of the list and ending up cancelling if there is no space. And we also want the diabetic patient to do first in the list. So this is something like openly known to everyone. So I prefer you to tell this in the exam. But given the choice, I have to do at least one to start with. So I prefer to start with the child because it's better to keep the child quickly because of the nil by mouth status, and while the diabetic patient needs to wait because of possible infection, he may have to be even last, and even the elective straightforward laser and ureteroscopy needs to be done before the fournier gangrene patient. And I'm glad that you rope in the emergency list to see if there is any capacity there to help you with the fournier gangrene. Good. You have any questions regarding anything till what we discussed?
No, thank you very much.
Okay. So we'll go to the next scenario.
Yes, please.
You have bought, your department has bought a new reusable cystoscope which can be used, flexible cystoscope which can be used in the wards, because in the ward sometimes there is a patient with difficult catheterization and it's difficult to get the patient filled into a elective flexible cystoscopy list. Sometimes a patient may have hematuria where you just need to do some diagnostics in the ward based. So the question is, it is a reusable flexible cystoscopy, and the company said this needs to be vacuum packed and sterilized. What does this sterilization involves?
So the sterilization is a process of removing all viable microorganisms, including even the viruses and the spores. And usually we have two methods of sterilization, either by the use of heat and pressure, which is the autoclave, which is the best method. However, the flexible cystoscopy is not compatible with this method because there will be damage to the flexi. We usually use this method for the rigid cystoscopy. The other method of sterilization is by use certain chemical, which is also not suitable for flexible cystoscopy. So for the flexible cystoscopy, usually we use the high level of disinfection, and this can be done by using fluid chemical solution like formaldehyde, glutaraldehyde, or peracetic acid. We keep it in for 10 to 45 minutes at a degree of 20 to 25 degrees centigrade, which this will give us a high level of disinfection. We should kill all the bacteria, all the viruses, but not necessarily all the spores.
What is meant by the vacuum packing and sterilization? What it involves?
It means that all the sterilizing instruments have been vacuumed from air, and then it's packed properly without any contamination, with a clear label about the date and time of sterilization.
Okay. What do you mean by ETO sterilization? What ETO stands for?
ETO?
Yeah, ETO.
I'm not sure. It could be
Okay, we'll come back.
ethyl alcohol, or I'm not sure.
Okay, we'll come back to that. What are all the stages of sterilization? Say, for example, clean and sterile and disinfected. Can you define them?
So cleaning is a process of remove all physical dirt and contamination will be removed. And then after that, we have the disinfection, which mainly include removal of most of the viable organisms, including bacteria, fungi, but not necessarily the viruses and the spore. And then sterilization, which should remove all viable microorganisms, including the viruses and the spore as well.
Okay, that's good. So
and we have a Spalding classification for the use of an instrument. So we have the critical, which means that sterile body tissue, and for sterile body tissue, we should everything used inside the body cavities, then it needs to be sterilized, like any implant, surgical instrument. So we need a sterilization for that. And then we have the semi-critical, which come into contact with the mucous membrane or non-intact skin. For this, we need a high level of disinfection, and this includes a flexible cystoscopy. And then we have the non-critical instrument, which come into contact into the patient skin, intact skin, like the blood pressure cuff or the tables or other things. And this will need a low level of disinfection.
Okay. Now, that ETO sterilization is the one which works with the vacuum pack. So ETO stands for a type of gas sterilization, ethylene trioxide. It is very useful for the instruments which are very fragile and susceptible to breakage, especially in high temperature or high pressure. After the ETO gas-based sterilization, the whole instrument will be gas packed, and it will be covered by 2 layers of plastics in the front and back, and you can see that it's like a blister pack where you need to open and then use the equipment. That is one of the easiest and the best method for using or sterilizing the flexible cystoscopies used in the ward. Okay?
Thank you.
Good. Let us discuss a scenario from the pediatric urology. The same scenario can be asked in the andrology also. A 17-year-old boy presented to the clinic that during erection he has got deviation of the penis towards the right side. He is not sexually active. He just noticed this during his masturbation. What may be the diagnosis?
So the possibility at this age is that it could be a congenital penile curvature, which could be an isolated penile curvature, or it could be part of more complex hypospadias. But usually when it is associated with the hypospadias, it will be ventral rather than to the side. Since it is located to the side or deviated to the side, I think about possibility of congenital penile curvature.
Okay. So what is the pathophysiology behind congenital penile curvature?
So this condition is commonly due to disproportionate growth of the tunica albuginea, or imbalance in the growth of the tunica albuginea between the ventral, between the sides of the penis, either ventral and dorsal or right and left. So it will be elastic or loose in the more convex side, and it will be a little bit more tight on the concave side due to disproportionate growth.
So, okay, how will you treat this patient?
So treatment of this patient now is much simpler, because previously they thought that this is mostly related to the associated with some urethral or corpus spongiosum abnormality. So there was a complex repair involving urethral mobilization, but most of the cases of CPC, they are isolated and not associated with urethral or corpus spongiosal abnormality. So it will be treated more or less in a similar way to pulmonary disease of the adult. So it will be treated usually by doing Nisbet or modified Nisbet procedure most of the time, and on the more concave side to correct the deformity, and also sometimes they do incisionless plication, which is just to apply plication without incision, which is similar to the Yakia repair. However, the success rate with the Nisbet is better than the incisionless plication.
Okay, now we move to a different scenario. How will you decide prophylactic antibiotic in a patient listed for theatre? What factors you will consider in?
I will consider the patient comorbidities and whether he is more liable to have any infection, like if he is immune compromised patient taking a steroid, renal transplant patient. Also about the disease of the patient, whether he has an infected problem at the moment, like abscess or something else, or we are doing a clean surgery for the patient. So whether it's a clean contaminated or contaminated surgery, and depend whether we are putting any prosthesis or not, depending on the expected microorganisms, whether they are mainly gram-negative, gram-positive, or anaerobic. And then accordingly, I can decide on the prophylactic antibiotic.
Could you tell me some examples for clean surgeries in urology?
So clean surgery in urology, most like varicocele ligation, inguinal radical orchiectomy, orchidopixy. Most of these surgeries, since there is no involvement of the mucosa of the urinary tract, then should be a clean surgery.
Say, for example, simple nephrectomy for a non-functioning kidney. How will you classify it?
I would say it will be a clean contaminated, because there is a potential risk of contamination during dissection and division of the ureter in this kidney, and we are entering a body cavity, so it will be clean contaminated.
So how will you use these factors to decide the prophylactic antibiotic?
So usually for the clean surgery, we don't need to give antibiotic unless the surgery involves a prosthesis insertion, then we need to give. For the clean contaminated, we need to give antibiotic, usually a single dose with the induction of anesthesia. While for the contaminated cases, we need to give prophylactic antibiotic at the time of anesthesia, and then to continue antibiotic therapy for a few days after that.
Okay, say for example you are doing a prosthetic surgery. Give an example in urology and what is your choice of antibiotic?
So, for example, when we do TURP, if the patient is not having a catheter, usually we prefer to give the patient something which cover mainly gram-negative microorganism, like gentamicin at a dose of 5 milligram per kg.
Okay, give example for surgery in urology which involves prosthetic placement.
So prosthetic placement, like when we put testicular prosthesis, for example, in this case, we are concerned about mainly the gram-positive microorganism rather than the gram-negative. So I need a wide spectrum antibiotic, including gram-positive like comoxiclav or second generation cephalosporin.
So how many doses you will give?
So usually for the prosthesis, we need to give a dose of at the induction of anesthesia, and usually I will cover the patient for 24 hours with antibiotic following prosthesis insertion.
Okay. What is the antibiotic of choice for transperineal prostate biopsy?
In transperineal prostate biopsy, in my practice, we are using ciprofloxacin 500 milligrams single oral dose 60 minutes before the procedure. However, the incidence of sepsis and infection in TP biopsies are very, very low at 0.16%. And I am aware of recent studies by Castellani from US, which compare patient underwent TP biopsies with or without antibiotic, and actually there was no significant difference in the infection, sepsis, and readmission rate between prophylactic antibiotic and no antibiotic before TP biopsy.
Okay. You said you used gentamicin, one of the commonest prophylactic antibiotic in urology surgeries. What is the dose? How will you decide the dose?
We decide the dose according to the body weight, and the usual dose for gentamicin is 5 to 7 milligram per kg, providing that the patient is having adequate renal function.
What is the dose for prophylactic gentamicin?
So for prophylactic gentamicin is usually I will give 3 to 5 milligram per kg.
Okay. What is gentamicin? How it works?
So gentamicin is a bactericidal antibiotic. It acts by inhibiting of the ribosomal subunit of the bacteria, and by this it inhibits the protein synthesis.
Okay. Is it a broad spectrum? What kind of organisms it will cover?
It's mainly cover gram-negative, but also it has some effect on the some gram-positive like staph.
So what about coamoxiclav?
Comoxiclav is a combination of amoxicillin and clavulanic acid, which is a beta-lactamase inhibitor. And usually it covers a wide spectrum of antibiotic, mainly gram-positive, with a good cover of gram-negative as well.
Okay. What is the dose for the patient?
For adult patient, comoxiclav is 1.2 gram 3 times daily.
Okay. What
Injectable.
is the... Sorry?
Sorry, this is injectable, and the oral is 625 milligram 3 times orally.
Okay. What is the antibiotic regimen for community-acquired epididymoarthritis?
It depends on the patient age. How old is the patient?
21. Sexually active.
Okay, so usually for the patient less than 35 years of age who are sexually active, we think about possibly an STI as a cause for epididymoarthritis, and therefore we give the patient something effective against chlamydia, mycoplasma. Therefore, I will give the patient usually a levofloxacin, 500 milligram once daily for 14 days, because levofloxacin is very effective against the gram-negative bacteria and also effective against chlamydia. If the patient is having discharge and the urethral swab is showing an Neisseria, gonorrhea, then we need to treat gonorrhea usually with a single dose of ceftriaxone given 1 gram IM, or a single dose of azithromycin 1 gram oral. So I will treat for 2 weeks.
Okay. Your theatre team is preparing mitomycin to be given after your TURBT for a newly diagnosed bladder possible TCC lesion. What is mitomycin? Why you have to give immediately after TURBT?
So mitomycin is antibiotic chemotherapy. It will act by inhibiting the DNA synthesis on the on the S1 and G phase of the cell cycle. It has a proven effect to reduce the recurrence of non-muscle invasive bladder cancer, and there are meta-analysis by Sylvester et al. Which showed that a single dose of mitomycin postoperatively following resection of bladder tumor, it will reduce the relative, there will be a relative risk reduction of 39% and absolute risk reduction of 12% if it is given early in the postoperative time to reduce the recurrence.
Okay, so how will you give? What is the dose?
So the dose is 40 milligram in a 40 ml of distilled water. Usually it is given immediately, in my practice, immediately after the TURBT. Make sure that there is no risk of perforation, there is no significant hematuria, and then the medication, usually it's a purple color, will be infused by gravity, by a special application system through the catheter, and the catheter will be clamped, and we ask the patient usually to move into different position. We keep the fluid usually for around 1 hour, and then after that we unclamp the catheter if there is a need to keep the catheter longer. Otherwise we can take the catheter out, and the patient will pass the mitomycin. We warn the patient and the nurses try to avoid contamination with the mitomycin because it may cause a chemical dermatitis of the palm of the hand and the legs. And I will put in the operative note very clearly the time mitomycin was instilled, the dose, and a clear instruction for the nurses in recovery to unclamp the catheter usually within 1 hour. After that, all the instrument or everything used should be go into a specific bin, which is a purple lead bin, and we should use a universal precaution during that.
Why you have to ask the patient to turn into different positions? What is the use of it?
In order to give the maximum exposure of all parts of the bladder.
Okay. What is BCG? What do you mean by the Bcg regimen? From where it's derived from?
So BCG is liver attenuated Mycobacterium bovis bacteria. It is used in a patient with high risk non-muscle invasive bladder cancer. Excuse me. So it's used in patients with high risk non-muscle invasive bladder cancer in order to reduce the chance of recurrence and the progression. It will act by induce a local immune reaction. When the BCG is given, it will attach to the epithelial cell via fibronectin receptor, and then after that, it will enhance the antigen presenting cell to T lymphocyte. Therefore, by this enhance the T cell mediated killing of malignant cell, and there is evidence that this will reduce the recurrence and the progression. Again, there is a meta-analysis review by Sylvester et al. Which showed a relative risk reduction of 27% and an absolute risk reduction of 4% in the progression of bladder cancer over 5 years with the use of BCG.
Okay, we'll stop there. As I said, I have no major concerns and nothing to suggest. You are on the right track for a very good exam performance and very good result. And I think you need some voice rest and take some prophylactic antibiotics. I'm not a person who support antibiotics, but before the exam, you can do anything under the sun to make yourself comfortable. And any help from us, please feel free to ring anytime. There is no office time, non-office time or anything like that. If you are free, we will try to do something tomorrow afternoon, almost the same time.
Yeah, thank you very much. Really appreciate your help and support during this time.
Good.
Thank
Have
you.
a nice evening.
For you as well. Thank you very much.